Okay, I think we should start now.
Yes.
My name is Prasad Dabesinghe. I'm from Sri Lanka College of Oncologists. Welcome to the 7th FARO webinar. As you know, Federation of Asian Organization for Radiation Oncology was formed in year 2014. We are relatively a young organization, but nevertheless, we represent the majority of the world population. So it's very important that we share our knowledge. And today's webinar is about bladder cancer. And the structure of this program is we will be having a corporate member of FARO presenting for 10 minutes initially. And then we will have our main talk by Dr. Nurad. After that, we will have panel discussion. Today's panelists are Professor Ananya Chowdhury and Professor Peter Hoskin from University of Manchester. They are Sri Lanka College of Oncologists. In fact, most of our trainees are either trained or examined by Professor Hoskin. And Ananya has been helping with our training program as well. So even though they are from UK, we consider them as sort of citizens of Sri Lanka. So that's why we have invited them for this panel discussion. And third panelist is Dr. Soo Yoon Sang from Korea. The corporate members are important part of FARO. At this point, we have 2 corporate members. And today, we'll be having a talk by Mr. William Starbuck, who will be presenting on behalf of Electa, and he will focus on high-field MR-guided SBRT for bladder cancer. May I invite William for the presentation.
Will, you're on mute.
Hey there, everyone. You can hear me?
Yes, yes.
Fantastic. Okay, thank you very much for the opportunity to present at this meeting. It's very, very much appreciated. And what we'd like to do today is talk about our Electa Unity and really how it combines 2 worlds together. So MR guidance and high quality radiotherapy in one future. So being able to deliver the best possible care for our patients going forward. So, since its inception, we've had over 42 sites actually have a Unity installed at their clinics, and 26 of those are in clinical use. So they're throughout the entire world in a variety of centres, and really shows the uptake of this technology and investment in this technology going forward. And it's really exciting to see more sites come online as we go forward. So really, one thing that can't be undersold about the Electa Unity is really that it all begins with a 1.5 Tesla MR system. And really this device provides diagnostic quality images, which really allow us to see the patient's anatomy like we've never been able to do before. It's based on the Philips Ingenia platform, and it's able to deliver high quality soft tissue visualization in a sub-millimeter spatial and then like millisecond temporal resolution. So this image was acquired at the University of Tübingen, and right from the first scan, clinicians were able to really appreciate the ability to visualize even the smallest metastatic lesion without the use of any sort of contrasting agent. So really, it's the image visualization cannot be understated. It's purely exquisite. one of the other aspects that we're able to do with the Unity is really how it really addresses the challenges of radiotherapy today. So it helps clinicians see clearly, to help visualize soft tissue, reduce PTV and ITV margins, improve treatment delivery, and reduce the overall treatment times and fractionations. It allows us to track and manage motion in all directions, which will eventually help spare OER toxicity, improve the overall local control, and allows us to continually adapt and optimize our plan based off the new geometric and dosimetric information that we observe. So all three, which enables us to truly accurately treat these patients. And finally, it's revealing to the clinicians the tumor's functionality and the biology during treatment via DWI and ADC mapping. And having those sequences be available to clinicians. So this information will enable the clinicians to easily track tumor response throughout the course of treatment like you've never been able to do before. And at no time cost to the patient or facility, making it possible to personally manage radiotherapy treatments throughout dose escalation or de-escalation for every single patient. And really with Unity, all these benefits are really a reality now. So really what I want to focus on is some real clinical evidence for the group on the meeting today, is really some great news from one of our sites at St. Vincent's in Genesis Care, which went live with Unity, and within the first few months, they were using the deformable adaptive workflow to treat bladder cases within 30 minutes. So the fastest time they had was 25.5 minutes, and they've been able to utilize a real collaboration with the Royal Marsden Hospital via our Elector Consortium group. So for this particular case, it was a 72-year-old patient with affected by muscle invasive bladder carcinoma. And the most interesting thing is she self-referred herself for treatment on Unity. So she had seen all of the information about Unity that's been available, and said that she specifically wanted to have her treatment on this machine, which is fabulous news. So the bladder was subject to large intrafractional positional, shape, and size variation. And historically, large population-based planning target volume margins have been used in an attempt to achieve an acceptable target coverage. And this result in excessive normal tissue and irradiation, but doesn't successfully mitigate against geographical target misses. So we were able to basically treat this customer with a full adaptive workflow. So that means that we were able to adapt perfectly to the patient's position every day to ensure that we accurately treated this lesion. And we're also able to use motion monitoring. So the motion monitoring on Unity allows the team to visualize and adapt to the varying bladder positions, shape, and size. Also, MR radiation therapy presents an opportunity to graduate to much smaller margins. So the current plan of the day approach is beneficial, but to truly adapt the patient's treatment on Unity will ultimately be able to address, the huge margins for such a variable structure, fraction to fraction. So for this lady, the clinician prescribed a radical whole bladder dose of 55 gray in 20 fractions. And the planning process involved MR fusion using MR scans taken 30 minutes apart to inform the PTV. MRI before treatment provides superior tissue contrast without any additional ionizing radiation risk. And when combined with the online adaptive replanning capabilities, Unity offered the opportunity to adapt the plan each fraction to the anatomical changes seen. And one of the things that was really interesting about this particular case is the RO felt very, very comfortable in being able to visualize and contour the base of the bladder as well, which is always an area of contention, especially with our traditional cone beam or even traditional CT scanning practices. So they had extreme confidence in being able to visualize and contour those areas. So being able to use the Unity to target the bladder tumor is attractive as it opens up opportunities to reduce the toxicity and facilitate dose escalation. Also seeing the bladder with the T2 sequences will always be better at high field, especially the inferior neck of an empty bladder, as we were talking about before, and allowing for improved auto-segmentation of the bladder and really a confident partial bladder delineation or simultaneous integrated boost possibility. So again, being able to visualize like some of the functional imaging like capabilities with the Unity allows you to dose escalate if you want to. So again, as I said, all of this was able to be done in less than 25 minutes, which is a fantastic outcome for this type of patient. So as I said, this patient was prescribed 55 gray and 20 fractions. And again, by using our M-beam approach, we're able to deliver a VMAT style delivery, which is very, very quick and very, very adaptable, which gives fantastic dose distribution. And again, that's a full daily online adapted workflow, which with MR guidance, which is fantastic. And as I said, this was all completed in less than 26 minutes. And again, something that can't really be undersold is really the collaboration between all of our sites. So every site that has a Unity system is involved in our consortium group, which is an international collaboration on protocol development, sharing best practice, and it really has meant that sites that have been wanting to implement these new technologies have access to a lot of times, the people who actually began these clinical trials, and it's meant that all of our Unity sites, the uptake of SBRT and high-end adoption has grown every single year. So I think we're up to around 60 to 70% SBRT adoption across all of our treatment sites for all of our Unity systems. Okay, and that's the end of my presentation.
Thank you, William. That was so William Starbuck presenting on behalf of Electa on high-field MR-guided SBRT for bladder cancer. It's very nice new technology. Hopefully, our members will be able to utilize these new technologies in future. Thanks again.
Thank you very much. Thanks for having us.
Next, I would like to introduce the main speaker for today, Dr. Nurad Joseph, MD, MRCP, FRCS, Consultant Clinical Oncologist, Ministry of Health, Sri Lanka. Nurad graduated from University of Colombo and did MD Clinical Oncology under Postgraduate Institute of Medicine, University of Colombo. And currently, he is the Vice Chair of Sri Lanka Cancer Research Group. And he is also the ETC member from Sri Lanka for FARO. He has co-authored a chapter on radiotherapy in bladder cancer in the textbook Treating Urothelial Bladder Cancer, published by Springer International. And he's also a reviewer for many national and international journals. And he's also serving in the editorial board of the Red Journal. And so he had won a lot of awards. Notably, he received Helen Peterson Research Award from British Uro-Oncology Group and the Presidential Award for Scientific Publication and Transitional Research Fellowship by the European Society of Medical Oncology. So, as well as he also participated in the FARO LDP program in the third FARO meeting. Nurad, Over to you.
Thank you. Thank you, Dr. Abesinger, for that very kind introduction. And thank you to FARO, Professor Tati and Iros for facilitating this webinar. I will be talking to you on organ preservation with radical radiotherapy in muscle-invasive bladder cancer. So after a brief introduction, we will look at bladder preservation, the evidence for it, and radiosensitization, and then move on to biomarkers and some future prospects. So we all know that 25% of all bladder cancers present with muscle invasion. And when you compare with a superficial bladder cancer, the mere invasion into the from the urothelium into the bladder muscle results in a drop in survival from about 90 to 95% to about 50 to 60%. So it is indeed a poor prognostic group of poor prognostic tumor, which has an unmet need to improve treatment options. In general, the prognostic factors are as for any cancer age, performance status, stage, renal function, hydronephrosis, and as we will see later on, tumor hypoxia, in general, prognostic factors in muscle-invasive bladder cancer. So there are two main treatment options for localized muscle-invasive bladder cancer. The primary treatment is either radical cystectomy or trimodality bladder preservation with a TURBT and radiotherapy with the concurrent administration of a radiosensitizer. There is some role for neoadjuvant and adjuvant chemotherapy in this setting as well. So just a brief summary of surgery. You have so it's radical cystectomy, and you obviously need a urinary diversion. It can be a conduit or a neobladder, a continent preserving neobladder. So surgery is, although it was once believed to be the gold standard, it has considerable morbidity and mortality, and in particular in survivors, there is an unexplained chronic renal dysfunction that sets in survivors of muscle-invasive bladder cancer who had cystectomy. On the other hand, a bladder preservation strategy comprising maximal transurethral resection of the bladder tumor, along with radical radiotherapy with one of the radiosensitizers, could be carbogen and nicotinamide, the hypoxia modifier, or 5-FU and mitomycin C, gemcitabine, cisplatin, along with adjuvant or neoadjuvant chemotherapy, is an alternative, and which is in clinical equipoise with radical surgery in this setting. So if you compare radical cystectomy with bladder preservation, surgeons will argue that in radical cystectomy, there is a 100% response rate because the tumor is removed, but you need a urinary diversion, and even a continent urinary diversion isn't quite the same as having your own bladder. It has, as I mentioned previously, high morbidity. On the other hand, radical radiotherapy will allow you to keep your bladder. Of course, 10% of patients will go on to require salvage cystectomy, and there would be also some rectal and bowel toxicity with radiotherapy, which with modern techniques we are striving to keep to a minimum. So some contraindications, some of them are relative, more relative than absolute. So multifocal disease, pre-existing bladder function, as well as the hydronephrosis, which is believed by some to be a relative contraindication. But I think those of us who do treat bladder cancer have successfully treated many patients with hydronephrosis. It is a prognostic factor, poor prognostic factor, but I wouldn't really put that as an absolute contraindication for bladder preservation. And of course, widespread carcinoma in situ. Some radiation oncologists consider a poor response to neoadjuvant chemotherapy as a contraindication as well, but again, I think that is more of a prognostic factor rather than a contraindication for bladder preservation. So there was an attempt to, we have two treatment options which are in clinical equipoise, and there was an attempt at performing a randomized control trial, the SPARE trial in the United Kingdom. Unfortunately, could not recruit the numbers that they the numbers required, and it goes to show the challenges of performing a clinical trial when you have equivalent options across two disciplines. So it was difficult to recruit patients, and this trial was terminated prematurely. But there is robust retrospective data. Now, this is a single institutional study showing that, at the face of it, it would seem that surgical patients do better. But when you consider disease-specific survival, you can see that radical radiotherapy is very much prevalent to surgery. And when you look at the prognostic factors, this is not a randomized comparison, it was just a retrospective comparison. You can see that radiotherapy patients are older and had more advanced disease than the cystectomy patients. So if you adjust for those confounding factors, radical radiotherapy is very much equal and equivalent to radical cystectomy. And this is a population-based study, again showing that once you adjust for the prognostic factors, cancer-specific and overall survival are equivalent in between radical cystectomy and radical surgery. So radiosensitizers, we have 4: gemcitabine, cisplatin, and mitomycin C, and carbogen and nicotinamide. The first radiosensitizer was cisplatin. It was delivered at 100 milligrams per meter squared twice weekly. This was one of the first studies showing improved local regional control. And then this is a study by Professor Chowdhury, where a single arm phase 2 study where there was survival, disease specific survival of around 75% with gemcitabine delivered at a radiosensitizing dose of 100 milligrams per meter squared. And then the BC 2001 trial, which is the largest phase 3 trial in muscle invasive bladder cancer, and that showed an improvement of 13% in local regional disease-free survival with the addition of 5-FU and mitomycin C. So apart from chemotherapy, another interesting strategy in radiosensitization in bladder cancer is hypoxia modification. So bladder cancer is one of the tumors where hypoxia plays a major role. And we know that hypoxia causes radioresistance, and it also induces a more aggressive tumor phenotype, and it could lead to greater metastatic spread as well as the local regional spread. And nearly half of bladder cancers have hypoxia. And so a strategy was devised in Mount Vernon Hospital by Professor Hoskin where carbogen, which is a mixture of oxygen and carbon dioxide, was delivered 5-10 minutes prior to and during radiotherapy. And it was, and concomitantly, patients were given nicotinamide, which was a rather high dose of nicotinamide. So some of them, around a third of them, had some GI toxicity. But this is a very cheap, cost-effective radiosensitization option, so much so that we used it in Jaffna, one of the previous centers I worked with, and Professor Hoskin visited us, and you can see him holding the breathing apparatus. So this is a very cheap, cost-effective option. You just need to, you can easily get carbogen from your hospital medicinal gases supplier, and they will make the required concentrations of oxygen and carbon dioxide, and it is very cheap and a very effective radiosensitizer with very minimal toxicity apart from the GI toxicity of nicotinamide. And the BCON trial by Professor Hoskin showed that actually this is the only trial where there was a overall survival improvement. The BC 2001 trial just had a trend towards improved overall survival. So you can see that hypoxia modification will impact on overall survival as well, for the reasons stated before. So just a bit about the radiotherapy technique before we move on to some of the recent advances in this space. So currently we treat the whole bladder. The dogma of whole bladder radiotherapy, the whole bladder as the clinical target volume still remains. And there are two fractionation schedules, the conventional and hypofractionation schedules that are used. And as you would see later on, one of these schedules have now proven superiority. So you can either deliver this as a conventional or conformal technique or PMAT or whatever form, but it's whole bladder and margin. One of the challenges we do face is, of course, so traditionally we treat these patients as with an empty bladder, but some bladders are more empty than others. And even in an individual patient, there can be considerable variation in bladder volume, even if you do treat them as an empty bladder. Even if you do ask the patient to empty their bladder, there's considerable variability in bladder volume. And so with the IGRT, we are able to, with cone beam CTs and IGRT, you can adapt a plan of the day approach where, depending on the variability in bladder volume, you can select one of the predefined radiotherapy plans depending on the bladder volume for that day of radiotherapy. So the recent advances have been just selected three main advances. And first is the hypofractionation meta-analysis of the BC 2001 trial and the BCON trial. And then the update of the BCON trial incorporating biomarkers, as well as the neoadjuvant chemotherapy update of the BC 2001 trial. Because these two, the BCON trial and the BC 2001 trials, are the only two randomized control trials in this space. So the radiotherapy fractionation meta-analysis was recently published, and that showed that the hypofractionation regimen was superior. Both the BC 2001 and the BCON trials permitted use of one of two regimens, either a conventional regimen of 64 grain 32 fractions or a hypofractionated regimen of 55 grain 20 fractions over 4 weeks. This was not a randomized allocations, it was just based on investigator choice. But a patient-level meta-analysis was performed, and this showed that the hypofractionation arm results in better local regional survival, as well as a trend towards improved overall survival. So the meta-analysis primary endpoint was non-inferiority, and since it was met, the investigator then proceeded to investigate superiority. So superiority was established in terms of local regional control, and non-inferiority was established in terms of overall survival, and there is a trend towards improved survival with the hypofractionation regimen. So as mentioned previously, the allocation of fractionation regimen was not randomized, but if you read the full paper in the meta-analysis, the investigators go on to show that actually the hypofractionated patients had worse prognostic factors than the conventional group. So in terms of toxicity, one of the concerns with hypofractionation is late toxicity, but as shown here, there is no difference in late toxicity between hypofractionation and the conventional fractionation regimen. So in conclusion, hypofractionation is superior in terms of local regional control. It is non-inferior in terms of overall survival. There is no difference in late toxicity. And clearly, a 4-week regimen is more convenient. It saves resources. And if it does improve local regional control, there is no reason not to adapt this as standard of care. So based on this meta-analysis, I think our practice should change, and 55 gray in 20 fractions should be the standard fractionation regimen. Next, we move on to the Beacon trial update. So this was an interesting study, and one of the good things about the Beacon trial was that tissue specimens were collected for biomarker analysis, and in the recently published biomarker update, 3 biomarkers of hypoxia were analyzed to see if it could predict patients who would benefit from a hypoxia modification approach. Now, this is groundbreaking in the sense that this is one of the first attempts to have biomarker-driven radiosensitizer selection. Of course, it was done retrospectively, but still, for all, it does provide us the basis to work towards biomarker-driven radiosensitizer selection. 3 different biomarkers were selected: necrosis, which is as simply classified by the histopathologist on the TURBT specimen, and then the mRNA hypoxia gene expression signature score, based on which patients were dichotomized into high score and low score. And also the molecular subtypes of bladder cancer was then analyzed, and there was a comparison made between basal and luminous subtypes. So the Beacon trial 10-year update confirms the benefit of hypoxia modification with carbogen and nicotinamide. Of course, the p-value, the purists say it's p-value 0.08, but that was because the median age of this trial population is 74 years, and there were a number of events that occurred in a prolonged follow-up. So I think the hazard ratio still holds, and this evidence is reassuring that the carbogen and nicotinamide improves overall survival. In terms of necrosis, you can see that if in patients without necrosis on the left side did not benefit from carbogen and nicotinamide, whereas in patients with necrosis, the addition of carbogen and nicotinamide to radiotherapy improved survival. So we can use necrosis, which is in our setting a very simple biomarker. Just get the pathologist to tell us whether there is necrosis or not. Of course, there are a number of issues related to this, subjectivity and of course classification of necrosis, but still I think the analysis is very robust. The same holds for the hypoxia gene signature, and with a high hypoxia score, there is benefit, and but there is no benefit in normoxic patients as defined by the hypoxia gene signature. Now, molecular classification, and just a word about that. So based on gene expression signatures, bladder cancers were classified as basal, luminal, and P53-like. And for this analysis, basal and patients were divided into basal and luminal types, and you can see that the basal type had benefit with hypoxia modification with carbogen and nicotinamide, but not so for the luminal type. And a bit about neoadjuvant chemotherapy before we move on to the BC 2001 update. So the meta-analysis showed that there's a 5% gain in neoadjuvant chemotherapy across patients treated with both surgery and radiotherapy. Of course, it's worth mentioning that in this meta-analysis, all patients received radiotherapy alone. So the study predated the use of radiotherapy with a radiosensitizer. So the question now arises whether neoadjuvant chemotherapy will improve survival in patients treated with chemo or radiotherapy, as well as whether the addition of chemotherapy to radiotherapy alone would improve outcomes in patients treated with neoadjuvant chemotherapy. Adjuvant radiotherapy, adjuvant chemotherapy, again, it's a smaller benefit, smaller evidence for that. All patients were surgical patients, of course, but some protocols, particularly in North America and particularly in America, many protocols deliver adjuvant chemo after chemoradiotherapy, even though there is no randomized evidence to support that. So the BC 2001 trial allowed investigators to use neoadjuvant chemotherapy at their discretion. It was used as a stratifying factor. And this update analyzed outcomes of patients treated with neoadjuvant chemotherapy. And 56 of them received chemoradiotherapy and 61 of them received radiotherapy alone. So the numbers are small, but it is still reassuring that even in patients treated with neoadjuvant chemotherapy, the addition of concurrent 5-FU and mitomycin C improves survival. So improves local regional survival as shown in this, this Kaplan-Meier plot. And the hazard ratios are very much similar to what was observed in the original trial. However, when it comes to overall survival, there was no difference. And but if you look at the whole, the original trial cohort, the entire cohort of patients, there was a trend towards improved overall survival in patients treated with chemoradiotherapy. So in summary, this update shows that the addition of radiosensitizing chemotherapy improves local regional control, whether it's regardless of whether you treated with neoadjuvant chemotherapy or not. But it is, of course, a non-randomized comparison. But when you look at overall survival, the curves separate out more in the original the whole study cohort than in the neoadjuvant subgroup. But this is a post hoc small subgroup analysis, so you can't read too much into that. But it certainly, given the fact that neoadjuvant chemotherapy trials predated the use of radiosensitizers, this analysis further questions the benefit of neoadjuvant chemotherapy in patients treated with chemoradiotherapy. And this is a study which I was involved in when I did my fellowship in Manchester with Professor Chowdhury. And in a small, of course, again, it's a small study cohort, but again, there was no difference in patients treated with neoadjuvant chemotherapy when you compare patients treated with chemoradiotherapy. So in summary, hypofractionation has superior local regional control, and necrosis and hypoxia gene expression signatures are robust predictive biomarkers, and you could potentially select patients who might benefit from radiosensitization with carbohydrate and nicotinamide, and chemoradiotherapy improves outcome, improves local regional control, even in patients treated with NAC. This is based on the BC 2001 update. The overall survival benefit of neoadjuvant chemotherapy, however, in the setting of bladder preservation with the use of a radiosensitizer is uncertain. And so we move on to future prospects. So there's a lot of interest in radiotherapy and immune modulation, more tumor-focused radiotherapy. Do we really need to, the role of maximal TURBT is being questioned, and there are some exciting developments in space of fractionation. Maybe we could see the dawn of personalized fractionation, as well as technical advances, as you just saw in the presentation by our corporate member. So immune system, this is just a summary slide. We do know that radiotherapy does work towards enhancing the anti-tumor immune response so that there is a more competent anti-tumor immune response. But some of the changes induced by radiation may also be counterproductive, and it may suppress this anti-tumor immune response. But this is a complex process. And we did this study in Manchester again, where in the cohort of patients treated with gemcitabine and radiotherapy, and we found that simple peripheral blood lymphocytopenia was a prognostic factor, and patients with lymphocytopenia did much worse than those who did not have lymphocytopenia. So this suggests whether if lymphocytopenia is indeed a biomarker of anti-tumor immune incompetence, then this is indeed a suggestion that enhancing the anti-tumor immune response may work synergistically to improve the effect of radiotherapy. And this is a single-arm study of durvalumab presented at GUSCO, again showing impressive complete response rates and very promising results, but of course a randomized phase 3 trial is needed before we are able to use these PD-1 and PD-L1 inhibitors along with in the space of radical radiotherapy. Moving on to tumor-focused radiotherapy, again, as I mentioned before, current dogma is to treat the whole bladder, whether it's cystectomy or radiotherapy. Our target volume is the whole bladder, but most recurrences are in the tumor bed. If we are able to escalate dose to tumor bed, or as well as reduce the dose, you might be able to improve toxicity and outcomes. Past attempts, however, at sparing bladder did not. There was a trial in Manchester, as well as the BC 2001 trial also had a randomization on radiotherapy volumes, but it failed to improve. It failed to reduce toxicity, and the non-inferiority of outcome could not be established as well. So, based on MR imaging and information on the TURBT, RADAR phase 2 randomized trial is attempting to investigate sparing the dose to the uninvolved bladder using group 2, or as well as escalating dose to the tumor bed. And this trial will report outcomes next year. And if it does show promising results, that would be very exciting, because for the first time, we could then move away from the dogma of whole bladder radiotherapy, at least in some patients. Next, we move on to, as I mentioned previously, so trimodality bladder preservation means that maximal TURBT is an integral component. So, however, it is questionable whether this really adds any therapeutic benefit. Sometimes performing a maximal TURBT could be counterproductive. It could delay your definitive treatment, whether it's surgery or radical radiotherapy. If there is perforation, by attempting to perform a maximal TURBT, it could facilitate tumor spread. And then imaging becomes complicated, and particularly if you're looking at tumor-focused radiotherapy, whose the effects of TURBT may confound your imaging. And of course, in patients who have had, in superficial bladder cancer patients who've had cystectomy for other reasons, it has been found that TURBT may understage the disease in about 20% of patients. And we now have good imaging modalities, and particularly modern MR imaging may be able to predict muscle invasion as well as good as done by TURBT. So the bladder PET study is investigating whether we could do away with TURBT, both in patients who are being treated with cystectomy, as well as in those who are being treated with radical radiotherapy. Next, we move on to personalized fractionation. So the meta-analysis, as mentioned previously, confirmed that hypofractionation is superior. And however, we do know that reoxygenation is the fourth R in the radiobiology of fractionation. So it is a way of overcoming, it is a strategy of countering hypoxia. And accelerated repopulation might be less prominent in hypoxic tumors. So although hypofractionation is superior across both groups, do we throw conventional fractionation out completely, is the question. And this is still work in progress, but Professor Hoskins and Professor Chowdhury's group did this study in the Beacon study, where they looked at outcomes by fractionation in the Beacon study based on biomarker expression of hypoxia. So in hypoxia low patients, that is in normoxic patients, you can see that hypofractionation did better. So in these patients, repopulation may be a more prominent factor, because the tumors are well oxygenated and the tumor clonogens can now proliferate rapidly. And therefore, the benefit of acceleration that hypofractionation offers would result in a superior outcome. But this benefit is lost in hypoxic patients. And because these patients these tumors aren't quite expressing accelerated repopulation as the well-oxygenated tumors. So therefore, the benefit of acceleration is lost. So this is just very, very preliminary work indeed, but we are, if this gets validated, I think we are looking at being able to choose fractionation schedules based on certain biomarker expression. It's a very exciting prospect for radiation oncologists. Again, this is the another plot showing that if the hypoxia score is low, then hypofractionation is beneficial. But when your hypoxia score is high, that means there is more hypoxia, it is not quite superior to conventional fractionation. And this was another modeling study that we did, which suggests that in hypoxic tumors, maybe we could adapt novel fractionation strategies, whereas in normoxic tumors, the focus should be on employing accelerated schedules, so we should not adapt a blanket fractionation schedule for all patients, like selecting radiosensitizers. The fractionation schedules too could be chosen based on biomarker expression. You've heard all about the MR-Linac, so basically MR imaging offers better spatial visualization of the bladder and more greater anatomic precision. But of course, in Asia, we have to really factor in whether this benefit does translate into tangible outcomes in terms of cost effectiveness. And then moving on to brachytherapy, which is the ultimate conformal radiation technique, and Professor Hoskin is a great exponent of this modality of treatment. And this was a large study, about around 300 patients, where brachytherapy boosts after a low dose of external beam radiotherapy showed equivalent outcomes. So that is another cost-effective way of boosting tumors in this setting. So lastly, I will end with this slide on bladder preservation in Sri Lanka. We are collecting data, and we did look at a small study done by one of the senior registrars, Dr. Praveen Thalanga, and it shows that we have decent overall survival outcomes with bladder preservation. Of course, we haven't embraced radiosensitization as much as we should. Probably a concern is toxicity, and this is where Carbohydrate and Nicotinamide offers us, would be indeed more convenient, more cost-effective, and less toxic than chemotherapy in our groups of patients. So, but it is indeed reassuring that we have decent overall survival outcomes with bladder preservation in our setting as well. So in summary, organ preservation is equal to radical cystectomy. The addition of a radiosensitizer improves survival. Biomarker-driven radiosensitized selection may be a reality in the near future. And hypofractionation leads to superior local regional control, and that ought to be the standard of care. Thank you very much, and we look forward to the discussion by our distinguished panel.
Thank you very much, Nurad. So, for the interest of the participants who have joined later, let me again mention about our panelists, Professor Peter Hoskin and Professor Ananya Chowdhury are from University of Manchester. I'm sure everybody knows Peter very well. His research interests are palliative radiotherapy, use of radiosensitizers, and brachytherapy. His current research program focuses on carbogen and nicotinamide, and he's the chair of prostate brachytherapy group in the ESTRO, and he serves in editorial boards of Radiotherapy Oncology and Journal of Oncology. And Ananya is also a member of the work stream of 2 National Cancer Research Institute Clinical and Transitional Radiation Research Working Groups. And he's also a member of NICE Bladder Cancer Guideline Development Group, and also a senior editor of the Red Journal. Welcome, all of you. And the third panelist is Dr. Soo Yoo-sang from Catholic University of Korea. And there are a few questions that have come up, and also, so how do we start this? Can I first invite either Professor Hoskin or Ananya to make some comments about the presentation?
Okay, well, my name was first, so I'll say something first. I think you had an excellent overview from Dr. Joseph on the non-surgical management of bladder cancer. I agreed with many of his points and disagreed with 1 or 2, but that may come out in the discussion. But I think he gave you a very comprehensive overview, ranging across the different modalities of radiotherapy, the role of chemotherapy, of hypoxia modification, biomarkers, and then bringing us right up to date with the potential role of the immunotherapy and perhaps personalized fractionation. So and congratulations to Dr. Joseph for an excellent presentation that gives us a very good background to any discussions we want to have.
Ananya?
Yes, it was an excellent overview, Nurad, and I wouldn't expect anything other than that with all your experience that you have in all those areas. I think what would be interesting would be really to discuss which aspects of the current management of bladder cancer we can use in our respective countries to try and improve the outcomes for patients. Nurad showed some very compelling data about outcomes in Sri Lanka, which, although are comparable to lots of other places, still show there's much room for improvement for this group of patients.
Okay, thank you. I first go to some questions which can be answered in few sentences. One question was about hypofractionated radiotherapy. Few were asking whether it is radiotherapy alone or with chemotherapy, concurrent chemotherapy. Ananya?
So we treat bladder cancer routinely with hypofractionation and either intravenous chemotherapy or carbogen and nicotinamide. So both the Beacon and the BC 2001 trials and the GEMX trial used hypofractionation alongside radiosensitization. And as you can see from the data that's been presented, there's no increase in long-term toxicity.
Is pelvic lymph node irradiation necessary in trimodal therapy in invasive bladder cancer? Pelvic lymph node irradiation, prophylactically.
Would you like me to take this one as well? So the trials that have been presented, none of those trials had pelvic lymph nodes irradiated as part of those protocols. There is one randomized controlled trial, to my knowledge, which actually comes from Pakistan's single center trial published in the Red Journal, which randomized patients to bladder alone versus bladder plus lymph node irradiation, and that showed no difference in the outcome. So certainly within my practice, I do not routinely irradiate lymph nodes, especially where there's no radiological lymph node disease. I guess for individual patients, there may be a rationale for doing that, but certainly for routine patients, I would advise bladder alone based on the evidence that we have at the moment.
Thank you. This question goes to Nurad. What was the main challenge in your center in Sri Lanka for developing and installing the carbogen as a standard of care?
Well, I think it was much easier than I expected. We just had to ask the medicinal gases supplier to provide us with the required concentration of oxygen and carbon dioxide, and the breathing apparatus was we had to sort of make our own improvised breathing apparatus that was again by helpful anesthesia colleagues did that for us. So it's really very much something that we can start very easily. Of course, you have to have some institutional approvals and so on, but once you have that, I think Carbogen is very much cost effective and very easily adaptable in our setting. And particularly, we saw from the Sri Lankan data that there is some concerns amongst the clinicians in treating patients with a radiosensitized chemotherapy because of toxicity. So I think in that space, certainly Carbogen nicotinamide is a very compelling radiosensitizer in Asia. And I think Professor Tati has been using Carbogen and nicotinamide for cervical cancer in Indonesia. So again, I think we have we have evidence to say that it can be adapted and translated into practice in Asia.
Thank you, Nurad. There was another concern about the bowel toxicity. Could I ask from Dr. Zhu Yu-sung about the bowel toxicity in hyperfractionated radiotherapy? Can you comment? And the question was specifically asking what are the bowel constraints in hyperfractionated radiotherapy?
Sorry. In most cases, when we're treating bladder cancer, the bowel is very close to bladder. So if we expand PTV margin, some considerable volume of bowel may be included in PTV. So I expand PTV margin and I exclude the bowel control from the PTV. So I usually avoid the maximal dose, max dose of prescription dose. So I do not accept the 66 gray more than I accept the point dose of 66 gray, but I don't want to more irradiated bowel for more than 10 cc for bowel. Then due to bowel toxicity, I usually choose non-fractionation dose schedule. So I usually use conventional fractionation dose schedule. So I want to ask other panels about hypofractionation.
Peter, can you comment? Can't hear you, Peter.
Sorry. Yes, I think there's undue concern about the bowel. I haven't seen a great deal of bowel toxicity at all treating patients, and I've been treating with 55 and 20 for the best part of maybe nearer 30 years than 20 years. So I think the bowel will tolerate 55 and 20 to small volumes. I think the big advance that has improved our bowel tolerance also is the adaptive approach, which Nurad outlined. Because there you do see the changes in bladder volume. And of course, the main arbiter of the bowel volume in your treated volume is the bladder volume. And as the bladder gets larger, it pushes bowel out of the way. As it gets smaller, you get more bowel falling down around it. But I don't see it as a major issue. I think it's perhaps unfamiliarity rather than anything else that gives people concern.
Could you give us figures of constraints?
Well, we have a constraint of the one I remember is 50 gray to V50, but it's true to say that the larger volumes, we often don't meet the full constraints, but it doesn't seem to be a major problem to small bowel, at least. Rectum, again, we have tight constraints in the V50 of 50 gray again, and I don't think we really see rectal problems at all. The main toxicity from treating the bladder is bladder toxicity, and we can't really avoid that, certainly as an acute problem. But if we look at the late effects, then they are generally very favorable and certainly comparable to those seen after radical surgery.
Thank you, Peter. On the same note, can you elaborate a little bit about the bowel toxicity due to nicotinamide?
Nicotinamide, yes, there is a specific bowel toxicity. It is toxic to the small bowel. And if you look in the Beacon data, something like 30% of patients discontinued the full dose of nicotinamide because of bowel toxicity. And that takes one of two forms, either nausea, usually nausea rather than vomiting, but often quite troublesome nausea, which doesn't always respond well to antiemetics. And in some patients, it does exacerbate diarrhea as well. And if you look again at the comparative data in the randomized trial, there was more diarrhea in the randomized trial in the nicotinamide carbogen group than the control group, which we certainly attribute to a direct nicotinamide effect. But it is transient, it's just an acute effect.
Okay. With regard to chemotherapy, what is the commonest regime that UK centers use? Is it mitomycin 5-FU or?
Depends on the center. Depends whether you're north or south of, well, Manchester anyway. So we would use mitomycin C5-FU, but I will defer to Professor Chowdhury for gemcitabine thoughts.
Well, all of in the recent Radiotherapy trial, which has closed recently in the UK, which was our national trial looking at adaptive radiotherapy and also boost to the tumor bed, Beacon, mitomycin C5-FU, gemcitabine and cisplatin were all permitted. And the data from that trial, which I guess is the best reflection of current UK practice, suggests that about 40% of centres are using mitomycin C5-FU, about 40% are using weekly gemcitabine, about 15, almost 20% are using Beacon, and then there's a couple of outliers that are using cisplatin. With the pandemic, to try and minimize patient footfall, I think a number of centres did move either to weekly gemcitabine during that time, at the same time that they moved to hypofractionation.
I wonder, Dr. Sung, what chemotherapy you use in Korea?
We usually using cisplatin-based chemotherapy. So when concurrently in our centers, we usually concurrent cisplatin monotherapy used.
And Dr. Sung, in your patient population, do you see all suitable patients, or do you see a certain type of patient for bladder preservation?
Pardon? Can you talk to me?
What sort of patients do you commonly treat for bladder preservation?
In our centers, usually in the region our hospital exists, there are very old population is dominant. So most patients considerable proportion of my patient is over 70s and in 80s. So the old population have comorbidities, and they had a higher risk of operation morbidity. So sometimes I choose bladder preservation because of their age and comorbidities. So associated TIS or multifocal disease is usually contraindicated for bladder preservation therapy, but I choose bladder preservation due to inoperability.
There was a question about how much CTV margin will be suitable for the low facility center. Question from, CTV margin. Nurad?
Yeah, so I think, we use whole bladder plus 1.5 to 2 centimeters. And as Professor Hoskin said, we haven't really run into very much bowel toxicity. Rectal toxicity, again, it's a bit more variable. So I think, you can very much meet the constraints and cover the CTV with the conformal radiotherapy. So I don't think you need to worry too much about. You can certainly adopt bladder preservation, even if you have if you are able to deliver conformal radiotherapy. So all the trials of BC 2001 and Beacon used conventional and conformal techniques. So yeah, I think toxicity is tolerable, and as our data shows, we have reasonable outcomes, even in our setting.
Okay, thank you. Any other comments from the three panelists? Peter, Ananya?
So can I just ask Professor Hoskin, now, given the compelling evidence for biomarkers in Beacon trial, would you now say that you would offer hypoxia modification based on one of those biomarkers, or would you say that we still need formal prospective evidence to embrace biomarker-driven hypoxia modification?
Well, I think I might take issue with your compelling, Nurad. It's a randomized trial, but the numbers of patients are quite small. And it's not what we call a qualification study. In other words, it is simply validating with test and validation sets. So I think in order to actually change practice worldwide, we would want to have a further randomized trial which looked at using the biomarkers to actually choose treatment and then randomize within those groups. I think without that, we can't really be sure what we're looking at and whether we are indeed looking at what we think we're looking at, or an epiphenomenon even. Necrotic tumors may just be very bad. I think we do need more evidence. And of course, the counter argument, and one I think which you've exhibited very well in Sri Lanka, is that carbogen is a very cheap treatment. And so actually treating all patients may be cheaper than doing biomarkers on all patients, for the moment anyway. Although necrosis may be, if we can validate necrosis, that may well be the one that is more transportable into other healthcare systems, certainly. But no, I think we have to wait a little, or use it for everybody, which of course is what I would advocate.
Thank you, Prof.
Thank you. Few more questions have come up. Concurrent chemoradiation after neoadjuvant chemotherapy with gemcitabine-based protocol. Is there any higher risk of bladder perforation? Any of the panelists can answer.
So we've looked at our data in detail on patients who've had neoadjuvant chemotherapy followed by GemX, and the paper is actually published in the Red Journal, and we didn't find any increased toxicity with those patients. I think it's about patient selection. So if you pick the patients who are fit enough and well enough for the treatment that you're planning to give them, then the patients get through treatment, tolerate it well, and hopefully have a good outcome. So we haven't seen that sort of increased toxicity in our practice.
Okay. Ananya, what is the dose of gemcitabine in the radiotherapy?
So in a 4-weekly schedule, we give 100 milligrams per meter squared once a week. The original trial was pure hypofractionation, so there was no 2-grade perfraction schedule. I have colleagues who use conventional fractionation, and they have given 75 milligrams per meter squared once a week without having too many problems with toxicity. There's another schedule that's used commonly, especially in the US, called the Michigan schedule, which is a twice-weekly gemcitabine schedule at a much lower dose per meter squared, but I can't recall exactly what that dose is.
Thank you. Next question. What is the rate of salvage cystectomy in these studies? Peter?
It's about 10% is the simple answer. I think if you look at the BC 2001, I think has actually published their cystectomy rate, and it is around 10%. And we have very similar experience in the Beacon trial.
Similarly, if you the published data on gemcitabine as well, whichever study you look at, there's a meta-analysis that's been published taking together all gemcitabine-based protocols. The cystectomy rate is 10 to 15% individually from the studies, with an average of about 12%. So most of us would say that the cystectomy rate is actually pretty low for recurrence. Some of these patients obviously relapse with metastatic disease, and some of these patients relapse with localized non-muscle invasive bladder cancers, and they are treated differently.
Yes, I think it's an important point to bring out that we also get a number of patients who on check cystoscopy have recurrent superficial bladder cancer, which we would treat on its merits as you would another superficial bladder cancer. So answering the question that I saw come up in the panel, I think if you need a salvage cystectomy, then that is treatment failure, yes. If you just have recurrent superficial bladder cancer, then I would not count that as treatment failure, because I don't think radiotherapy would be seen as an effective treatment or prophylactic for the development of superficial bladder cancer. And that simply reflects the field change in the urothelial mucosa that we see in these patients.
Could I ask a bit of a provocative question, Prof? Non-invasive high-grade bladder cancer using radical radiotherapy, chemoradiotherapy.
I think it should do, but I don't think we have strong evidence to support it. I mean, it seems anomalous, doesn't it, that you have exactly the same animal sitting on the surface, and it's not treated with radiotherapy, and you have exactly the same tumor invading muscle, which ostensibly you think is worse, and yet that seems to do better with radiotherapy. So I think the new trials need to be done, to be honest. I think we all look back at was it BRO1 or BRO2, which looked at the role of radiotherapy in superficial bladder cancer and showed very, very poor results. But I think we need to question that, and I would certainly support a new trial, maybe a new FARO trial, looking at the role of radiotherapy in superficial bladder cancer. Perhaps taking those patients that would otherwise go for cystectomy, with recurrence or progression of their histology. I think carcinoma in situ is also another difficult area, and I can sort of try to understand why radiotherapy may not be as effective in an in situ cancer. And that is clearly, again, a very difficult situation to treat. But yeah, T1G3 it's always difficult, particularly in the elderly patient who is not fit for cystectomy.
Any other comments on that from other panelists? Okay, I think we have 5 more minutes. As Con has shown as a comparable radiosensitizer to chemotherapy, what are the panelists' view of the low uptake of Con, that is Carbogen, in centers worldwide? And how do you advise countries that want to install Carbogen? Prof. Peter?
Well, I was going to pass that question to Nirad because he's done it. And,
Okay.
he can tell you all the pitfalls.
Yeah.
I think it's conceptual. I think we're just not trained to give gases, and then you can think of all sorts of reasons why not to. And also, it's slightly unfortunate it's Carbogen and not pure oxygen, although pure oxygen is difficult to actually administer on a continuous basis, certainly at 100%, because Carbogen then needs you to acquire a special gas, if you like, even though it's only 98% oxygen, 2% CO2. But it does require you having that negotiation with your suppliers locally. But it's not, as I understand it, and I can't mix gases, but as I understand it, it's not a difficult process for any gas supplier to provide you with Carbogen. But I think I'd be interested to hear of Nirad's experience and his advice to other countries, because he introduced it into Sri Lanka within quite a short time, Nirad, wasn't it? It was within well, you can tell us, a year or so. But there was a lot behind the scenes.
Yeah, I think so. I think first is, as Prof said, we have to sort of embrace it, and there is no cost, no financial constraints compared to some of the other technical advances, challenges we face in bringing new technology. So I think in terms of approval, institutional approval, in Sri Lanka, we have that advantage. So we were able to sort of obtain those approvals quite easily. But I do understand that in some of the Western centers, even though it's quite a cheap gas, you still need to do a lot of paperwork and business cases and so on to get that through. Yeah, I think it's a matter of doing it simply as a call to action. Actually, the data from Prof. Hoskin's trials. I think Prof. Tati is here, and she, I think, also embraced Carbogen in cervical cancer. So maybe she might be able to shed some light about using Carbogen in our region.
Tati?
Yeah, I'm sorry. Yes, we have a trial using the Carbogen for the cervical cancer, and the result is quite good. Carbogen combined with I forgot because it was already a long time ago. Yeah, I think that we can do, because Carbogen is very cheap, 98% of oxygen. I think we can do it for the in the low and middle and low middle income countries. Thank you. I don't know for the bladder cancer, but for cervical cancer, it works good. Thank you, Nora.
Thank you. Yeah, I think we have come to almost the end of the webinar. Before concluding, I would like to invite each panelist, if you have any sort of thoughts that you could not share, take about 2 minutes and make some concluding remarks. We'll start from Dr. Zhu. Any comments, Dr. Su?
No.
Thank you very much for your participation as a panelist. Professor Ananya?
I think it's been a really interesting discussion, and I can't believe there are over 200 attendees. I didn't realize that bladder cancer was so interesting to everybody. I think it's a real starting point for all of us to be able to select patients to offer bladder preservation. Radiotherapy alone, as Dr. Joseph has shown from his data, works well, but it can be significantly improved by the addition of a radiosensitizer. And although that can be chemotherapy, there's a clearly easier, cheaper way of radiosensitizing using carbogen and nicotinamide that's very well tolerated and gives excellent results. So it would be great to reconvene everyone in a couple of years' time and see whether we've managed to do more bladder preservation throughout.
Thanks. Nurat?
Yeah, so I think the evidence is clear that bladder preservation is equivalent to surgery. And we have a number of radiosensitizers, and clearly in our region, carbogen and nicotinamide stands out. And particularly if you are concerned about toxicity with the addition of a radiosensitizer, then you have that modality. You have carbogen and nicotinamide, which would suit your patients more. So I think hopefully we can preserve more bladders and improve outcomes across our region. And yeah.
Thank you very much. Lastly, I would like to invite any more comments from the Edc Committee or the FARO Council member. Do you have any comments or any messages? Or
I just like to make one comment. It was a very, very good webinar. Thank you to Dr. Joseph, and also the great contribution from Professors Hoskin and Professor Ananya. Thank you very much. And Dr. Sun from Korea. It was very great. Thank you. Okay.
So let's conclude this 7th FARO webinar, and we'll meet for the next webinar. I think it is by Malaysian Oncology Group, next webinar in next month. Thank you very much for Indonesian group for supporting the logistics of conducting this webinar, and our British colleagues as always, and Dr. Su, the main speaker, Nurat, and Tomo, and all the FARO members. I think it's a good, overall, very good webinar, and we learn a lot from it. And maybe it's a practice-changing webinar, I can say. Thank you very much. Good afternoon and good morning to UK colleagues.
Bye.
Picture?
Picture? Okay.
Thank you.
Yeah,
Thank
picture.
Shall you take a picture then?
Yes, please, everyone.
Can you turn your camera on?
Please turn on your cameras.
Melinda, admin. Anita, where are you? Anita.
I have asked for unmute, Prof.
Anita. No.
Okay, Tomo, you can do it.
I can do it.
Mayan, or who's doing
Yes.
it?
Okay, Dr. Nico will take the picture, please.
Okay, I will take the picture. So please, everybody, please smile. 1, 2, 3. Okay, one more time. Okay, smile, big smile. 3, 2, and 1. Okay.
Thank you very much.
Thank you. Thank you.
Thank you
Bye.
to Maya, Melinda.
Thank you. Great job.
Thank you. Bye.
Excellent.
Bye.
Bye.
Bye, Miriam.
Bye, Tati. Bye, everyone. Junli,
Bye, everyone.
Tomo,
Bye. Thank you.
Bye, Mariam.
Dr. Prasad, Dr. Nurad. Thank you.
Thank you.
Yeah,
so
great
much.
job,
Thank you.
Nurad.
Thank you.
Thanks, Tomo. Thanks. Thank you.
Congratulations.
Thank you.
Junlin, Dr. Prasad. Thank you.
Hello.